Welcome everybody to this ERA e-seminar, which today is organized by the CKD-MBD working group. The mission of the CKD-MBD working group is to encourage research, education, and communication in the field of chronic kidney disease, mineral bone disorders. Actually, this is the mission of all working groups, but they all focus on a different field within nephrology. Can I have the next slides? Today, we will listen to Professor Ziad Massy, and he will explain to us how CKD-MBD gets complicated over the years. The topic of today is the role of microbiota, how intestinal microbiota can affect CKD-MBD, and the emphasis will be on the actions of PTH. In addition to Professor Massy, we have Professor Koppe from Lyon in France, and also Bjorn Meijers, Professor Meijers from Leuven in Belgium. And they will ask several questions, but please feel invited as audience to also pose questions, and you can do so by using the Q&A button, which is in the lower part of your screen. My name is Marc Vervloet. I'm a nephrologist in Amsterdam. I will moderate the questions you may raise or moderate the questions by the panelists.
I would like to follow this outline. I will remember you all the new data related to status of secondary hyperparathyroidism in CKD. We will have also some gut microbiota in CKD, all the new data. And the major part of the discussion and the presentation will be focused on the role of microbiota and modulating the action on parathyroid hormone. Let's start with all of you are aware that once the GFR decrease, there are gradual increase of the level of PTH. Actually, the PTH increase in important manner in CKD stage 4 and 5, where they have slight increase before. 3 molecules are responsible for increase the secondary hyperparathyroidism in our patient: hyperphosphatemia, hypocalcemia, and low level of calcitriol, which increase the secretion of parathyroid hormone, but also they do modify the proliferation of the cells, parathyroid cells, to do hyperplasia in addition to other molecules. PTH act by 2 receptors, PTH1R and PTH2R. They share some intracellular signaling, but they have a different also intracellular pathway. They are present in parathyroid hormone, but also in T cells. What is well known at the level of the bone, that PTH, the bind to the PTH1R, which are present in osteocyte and osteoblast, decrease the secretion of production of sclerostin, and then stimulated osteoblast activity. Once osteoblast stimulated by PTH in the presence of sclerostin, they can secrete Ronkel and activated the generation of osteoclast. This is binding is very important, and the role of sclerostin in DDK production is really well documented in CKD situation. Well, I just want to let you know that, as we said, that we always assuming that the majority of abnormal bone disease in our patient is high bone turnover. But remember this is related to associated with the PTH and phosphate, which only increase in stage 4 and 5. If you are in stage 2 and 3, there were no increase of PTH or phosphate, but you have also some microbiota product like uric toxin, indoxysulfate, sclerostin, and FGF23. And then you can find low bone turnover. We did a study with the Brazilian collaborator to see the biopsy in this patient, stage 2 and 3 and 4 and 5. You can see in stage 2 and 3, there are less small increase of PTH, not significant, as well as small increase of FGF23. If you look what happened in the biopsy, you can see that osteoblast surface, osteoclast surface, and more important, the bone formation rate is very low in CKD2 and 3, and this in comparison CKD4 and 5. All the patient was vitamin D repleted. What is interesting to introduce the talk today, that when we have the association between some of this histomorphometric bone data, let's focus, for example, to bone formation rate. You can see there are two molecules associated to this bone formation rate, PTH, but we know that, but some of our product is coming from Microbiota with andoxyl sulfate. What is the situation of Microbiota and CKD? There are a few years ago, 10 years ago, they hypothesized that they have, we have dysbiosis and this microbiota, and use enlargement of paracellular pathway in the intestinal barrier, allowing to translocation of bacteria and bacteria product and uremic toxin. We have recently, in collaboration with CKD-MBD, have this confidential non-published data, look about the comparison with 68 patients with CKD in comparison with the patient matched with age, sex, and BMI, and, but have normal renal function. We look at alpha diversity, we can see this is enrichment of microbiota, there were no difference. However, if you look at the beta diversity, which associated this, what we call a different type of microbiota, you can see there are difference between green, which is CKD, in comparison between control, which is significant. More importantly, that gut microbiome health index, which indicating the dysbiosis index, was negative. And usually it's very important is lower in CKD patient is also significant. So there are no quantitative modification, but qualitative modification of CKD. The product of microbiota is multiple. There are, all of you are aware about this amino acid metabolism like tryptophan or tyrosine, but there are also other molecules like the short fatty chain fatty acid. One of them is butyrate, which is our interest today. What is the short fatty acid? It's short fatty acid is the major anion and present in 100 millimolar in the intestine. They are produced by bacterial fermentation by undigested carbohydrate. There are four molecules, C2 acetate, C3 propionate, C4 butyrate, and C5 valerate. And the concentration is colonic lumen is 16% acetate, 25% propionate, and 15% butyrate. And you can see they are linking to two receptors, G protein coupled receptor, which is orphan1, GQ and GI, GPR41 and GPR43 to have their action. There are different sensitivity to link as a ligand to GPR41. Propionate is more sensitive than butyrate and acetate, while in GPR43 is equal sensitivity for three of them. Let's focus on butyrate for our talk today. Butyrate is, as you know, this digestion of fiber. Butyrate increase expression of tight junction in epithelial cells. This is mean that protect against this enlargement of paracellular pathway intracellular between the cells. And that also additional effect in inflammation and translocation, which has been used actually for example, for when you have colitis linking to Clostridium difficile. In addition to the action in intestinal barrier, the butyrate can be reabsorbed by two receptor, carboxylate transporter and sodium couplet monocarbonate transporter to reach the circulation and go to fix in their receptor in different tissue like adipose tissue, pancreatic tissue, kidney tissue. It give a different effect in the body. What is the situation of butyrate in our patient? There are conflicting data, and one of them is a study I show you coming from China, showing that fecal butyrate decrease with the progression of CKD, and as well serum butyrate. And this was well correlated with GFR, low butyrate. We can maybe assume we need more data to show that, but it seems that butyrate is in the situation of deficiency in our CKD patient. Let's move to the effect of microbiota and parathyroid hormone. The majority of the work done is coming from Professor Pacifici from Atlanta, United States. And he published initially the work related to parathyroid hormone and bone formation, which be modulated by butyrate production. Before his paper in GCI, he published this paper in Immunity showing that if you give lactobacillus or increase butyrate, you are modifying immunological system by activating CD4s, and they have this receptor GPR43, modifying then Treg, modifying CD8, and increase WNTB. And by increasing WNTB, you have a transformation from stroma cell to osteoblast and increase the bone formation. He asked a question whether this action of butyrate can be associated also with well-known factor modulating bone disease. And they use intermittent PTH. And as you see here, for example, when you in control, when you have intermittent PTH, you have improved bone structure. However, when you use the germ-free or antibiotic treated animal, they mean that no microbiota, there are no effect of the formation of intermittent PTH. They look why is that, and one of the idea is looking about the level of serum butyrate. You can see here, the mice without antibiotic, when you treat them, they have low butyrate, and they supplement the butyrate to this animal. But they can see here that, for example, the bone volume decrease when you have antibiotic and restored when they have the butyrate, meaning that butyrate play a role in modulating when you infuse PTH. I will make the long story short. It depended the level of butyrate. If you have normal level or slightly elevated, they can modulate the effect of PTH in immune systems. So they can modulate the effect on CD4, Treg, CD8, and WNT. If you have high level of butyrate and then you can have additional effect than PTH by increasing the activity of dendritic cell through this GPR43. So very important thing showing that this is a collaboration between butyrate and PTH and mice. So remember, I showed you a few minutes ago that PTH can link to PTH1R, inhibiting sclerostin and DKK production and increase the level of the bone formation. Now I show you that you have PTH can activate the T cells. T cells have a receptor for PTH1 receptor, modify also WNT10 pathway, and this effect can be reinforced and modulated by butyrate. The same group was looking about the bone loss and using by continuous elevation of PTH and to show that they modify TNF cells, especially TH17 cells. And this can be microbial dependent. They knew that CBF, segmented filamentous bacteria, is modulating immunological system. This has been published before. So they supplemented this mice with CBF plus and have the infusion of continuous PTH. So this is mice have, when you have infusion of PTH, when they have also segmented filamentous bacteria, they lose bone. This is a bone resorption increase. If you treat this mice with antibiotic, you lose this effect. Note that if you don't have CBF, CFB in mice, there were no effect at all in the bone resorption. And then they look about histology and bone volume. They see that non-antibiotic treated patients have a decrease. And then when you have a treatment with antibiotic, you restore. If you have segmented filamentous bacteria, if you don't have, there were no effect at all. They go further to explore the mechanism behind that. And they saw, for example, that it's the chronic infusion expand the secretion of IL-17 through TNF cells in the intestine as well as in bone marrow. You can see here, but when you treat them by antibiotic, you lose this effect. Note that segmental filamentous bacteria is not only going through modulation of immune system, but also can be affected by the metabolism of lactate to butyrate. And there are all the studies showing that butyrate can block this transcriptional factor called NFATC, dephosphorylated to be active to induce pre-osteoclast differentiation. And as you can see here, that butyrate block the differentiation and action to the this NFT and the DNA. So the butyrate by itself can be a blocker for osteoclast. So just remember you again that bone formation rat, what we find in our patient, that we have this collaboration between intact PTH and some microbiota, but the role of endoxysulfate in that is need to be explored. I finish and just let you to what take home message. The first message that intestinal microbiota modulate the effect of PTH. Intermittent PTH have a direct effect in the immune system and then have a Wnt activation and have bone formation. This can be reinforced or even pushed by butyrate, which coming from the intestine. If you have continuous secretion of PTH, is going through the segmental filament bacteria, which also microbiota modulate TNF cells, TH17 cells, increase secretion of different cytokine, and block the differentiation from monocyte to osteoclast. So increase the bone resorption. And we have this, could be this segmentally filament bacteria can modulate this level of butyrate, which also can modulate, block the transdifferentiation. All this data was, let's say, in animal. What happened in chronic kidney disease? I show you that it may be we have less butyrate. What happened of this butyrate and an effect on continuous PTH elevation in our patient need to be explored. What happened if we supplemented this patient with the butyrate about this continuous PTH? We need to explore it. So there's a lot of work will be done, but it's important thing that to keep on mind that the PTH is not only the actor of bone modulation, remodeling, but it's also, we keep in mind that some of our product of microbiota can play a role. Thank you for your attention.
Thank you very much, Ziad, for so clearly explaining such a difficult topic. You did it very condensed, which is perfect. So this gives us time to pose a few questions. And I know we have questions from the panelists, and I also noticed there are already 2 questions from the audience. You still have the opportunity to put additional questions to the Q&A. But first, I would like to ask Bjorn to ask some questions on Ziad, for Ziad.
Thank you, Marc. Congratulations, Ziad, because you brought together, I think, 2 very complex but also very important topics in CKD, that is of CKD-MBD and the role of the microbiome in CKD, and bringing these together makes the story for both parts even more complex and challenging. Now, in the first part of your presentation, you discussed the complexities of CKD-MBD and mentioned a number of different markers, including PTH, but during the remainder of the presentation, you focused mostly on PTH. Is PTH the most suitable marker in this respect of CKD-MBD? And do you think there are other markers that would be interested to look at with respect to the implications of the gut microbiome?
Thank you, Bjorn. I understand, I expect the question. And let me move to this one, show you that the other product than the PTH can play a role on bone remodeling, which is coming from gut microbiota. I have no time to explain all of them, but this has been published already. The calcium balance on the endocrine system, like EGF-1 especially, and in addition to immune system. So yes, you are correct. There are other molecules than PTH can modulate bone metabolism.
Thank you, Professor Massy, for this very nice presentation. I really appreciate, and it's opened a lot of new pathway to explore. And I just would like about your reflection about since over the last year we have seen a lot of publication about the microbiota in CKD, and most of them are cross-sectional association study. And what are you focused on this respect to the role of the butyrate and hydroxyl sulfate? And also, are we looking at yet another association, or are we looking at causality of a CKD-MBD phenotype? So do you think it's only an association, or do you think it's a causality what we observe?
You mean that the modulation of microbiota can modulate the bone? No, I think it is, and somehow if we take butyrate, or this is a segmental filament bacteria play a role, it's causal, because both of them have been shown to modulate immune system, and both of them can play a role to modulate the osteoblasts and osteoclasts. So yes, they are causal. And what we don't know, I agree, we still need to think about it. What is the role in CKD patient? We need to confirm the data showing that butyrate is decreased or other molecules. And what happens if this is the causality is coming, if you give butyrate and you see a modification of the effect of PTH in our patient. This is nice. RCT trial could be done if we believe that.
Question from Pablo Urena, also from France. How do the authors of the JCI paper reconcile their data with previous data showing a quantitative decrease in the number of bacteria, namely firmicutes in CKD?
Well, I think the author of the paper didn't look for CKD. We did look for CKD, and this preliminary data we have with Letitia actually participated this work. So we have a different result as we see in the literature before. There are some modification. Let's say that this is maybe intermediate change, and they do have total number is not changing, but we still have a different type of bacteria, and this is what we call dysbiosis, this kind of type of bacteria, which has been also published already by the literature.
Okay, thank you. So one more question from the audience, and then I come back to you, Bjorn.
Okay.
This is a question from Peter Sawaya. Since butyrate is only 15% of the short fatty acids, what about the other? Do they have a bigger role?
Yeah, well, we don't know. I mean, just I think it is related to the receptor having butyrate have a good receptor and have been studied with different disease like kidney disease, adipocyte tissue, and butyrate can be reabsorbed in addition to have the intestinal effect. So the question is, what we saw in PTH is related not what happened in the intestine, but it's what happened in the blood, on the serum circulating butyrate. And I show you that in CKD, for example, if you have both, you decrease the production of butyrate in the intestine, but you have a decrease in the blood. I don't know what happened for other molecules, and they have special receptor related to immune system as well as osteoblast and osteoclast. So cannot answer this question.
Thank you. Another research to be done. So Bjorn.
Yes, I want to continue on what was just discussed, Ziad. You just mentioned that you observed together with Letitia some changes in the microbiome. And I think that a number of publications have actually shown this, that there are changes in the microbiome. However, it was not really possible to delineate, I would say, the uremic microbiome. You see changes, but these changes differ a bit from one study to another, and they not all studies point to, I would say, a signature microbiome that's typical for CKD. Also, we talk a lot about gut microbiome as in the gut microbial composition, but we have to keep into account that these microbiota also have microbial metabolism. And from some studies, also from our colleague from Ghent, it's quite clear that there's no one-on-one relationship between the gut microbiome composition and the gut microbiome metabolism. So for me, it's quite difficult to understand how this then gives a fixed effect on CKD-MBD, because there are differences in the individual microbial composition and difference in the individual microbial metabolism. So how can this contribute to CKD-MBD in most of our patients then?
Yeah, I fully agree with you. The modification of microbiota is one possible factor to change the level of uremic toxin, or what we call short chain fatty acid. But the diet is play a role. If you look about, for example, one uremic toxin, like as you did paracrasyl sulfate or andoxyl sulfate, the average level is higher, but standard deviation is large. So you have patient with high level of andoxyl sulfate and patient with almost normal level of andoxyl sulfate. This means that the microbiota is one factor, and we are looking actually in this in our study about the role of diet and how they can modify microbiota and how they affect uremic toxins. So agree that microbiota is not only factor can influence that. And clearly we are multifactorial modulation of this drug. Actually, some of the data coming from Ghent, they show there are no intestinal effect at all, but they put all this modification of uremic toxin related to decrease of clearance of GFR and and tubular one, but I believe this is both, and that we will see what we have in our patient, and this study is a progress.
Yeah, I completely agree with you that it's probably an effect both on the gut microbiome and on renal handling of these metabolites.
I would like to you present the potential role of endoxysulfate and short fatty acid in the CKD-MBD, but in the literature, do you think that we have already identified all relevant microbial metabolites, or do you think we are very far of the understanding of the metabolites that could play the role? Do you think in the future we will have some data about the link of the new metabolites and the CKD-MBD, or do you think butyrate and endoxysulfate is the major one? What is your opinion about this?
Yes, I think that you are correct, Letitia. This is actually Peter Sawaya question, that it's 15% of butyrate, that it is only one, but there are other. I mean, you have also, in addition to what we call the short fatty acid chain, and we can have different molecules also produced by this microbiota, and you can have also, I think it's other way around, when you have the consummation of amino acid. So you do to make this uremic toxin, low level of tryptophan may play a role also to have the toxicity too. So this is what we call amino acid, branched amino acid, as you know very well. So the story is very complicated, but one important thing is, to my opinion, is this is I learned when I start. If we have this butyrate available, we show that at least in animal model they have an effect in modulating of PTH. So the second question is to look what happened in our patient. What the level of butyrate, what in fecal, or what the level of butyrate in the blood, what the difference of bone disease or even calcification when they have low level of butyrate, and then go to RCT to see what happened if you supplemented them butyrate. But I think it's always like, for example, we learned recently that if you want to have an action of tryptophan, endoxyl sulfate, EIA, other molecule, kinurin, all of them work for AHR with the receptor. So if you block one of them is not enough. You need to block many of them. And in addition, you block one only tryptophan, but you still have tyrosine metabolism. So this is a reason we think is microbiota maybe and hope for the future, because if we can find some bacteria which can restore what we are needing for the future, for example, for bone disease or even for progression of renal disease or cardiovascular complication, this would be nice.
Ziad, I take the liberty of being the moderator and asking a burning question, if you allow me. So I can imagine that this interconnection between immune cells and bone takes place at the intersection of bone marrow and bone. So this would be medullary bone and not cortical bone. But in clinical hyperparathyroidism, it's the cortical bone which is thinning. So how do you reconcile the findings of the JCI paper with clinical hyperparathyroidism?
Yeah, you are correct. That in the paper of GCI, the only trabecular bone was modified, that not cortical. And I agree with you that in human data in CKD-MBD is completely different situation. But in GCI, they look in bone formation, like they look in bone resorption. So I think it's could be the effect of butyrate in bone resorption has been published in different paper. I show you this paper blocking this NFT-C1, which is responsible for the differentiation of macrophages to osteoclasts. So I don't know what happened for butyrate related to the cortical bone and for bone resorption, because I believe that initial step in our patient is, if it's true, is a dynamic bone disease in CKD stage 2 or 3. We will have hyperparathyroidism later on, and certainly in dialysis patient.
Mm-hmm. I think you already mentioned it, and this is also a question that always makes things complicated. A lot of the results that we've discussed today are from animal experimentation, and typically we use either rats or mice, and both from the perspective of the microbiota and from the perspective of the mineral and bone disease, the question is how representative these animals are for the human situation. What's your thought on this? Because we struggle with this. I mean, we do rat experiments ourselves, but these animals are coprophagic, so they eat their own feces, so they actually get short-chain fatty acids and microbiome metabolites in the upper GI tract, and hopefully most of the patients do not share the same habit.
I agree that the mice and rat is the model, but we have looked like kind of meta-analysis with Tillman-Drucke published in the paper when we wrote about this clinical data showing that we have low bone turnover in CKD stage 2 and 3. If you take the model when they have only moderate elevation of creatinine or moderate decrease of GFR, which kind of CKD 2 and 3, all of them have low bone turnover. If you have advanced model, when they have low, very deep decrease of GFR, then they have hyperparathyroidism. So the model is, and the mice is working. You can look the table we published about that. When you have this slightly elevate creatinine and decrease of GFR, you have low bone turnover. When you increase, when you progress, and then you become independent, autonomous, what have you. So I'm not sure it is not representative fully, but the model, for example, with calcification in this mice, we did a lot of work. It's completely different. They are more frequent in female than male. They start in aorta valve, progress, which is completely different for a human, but it is the model. But I think what we look, when we look actually in our model about bone disease, other look about that, when you have moderate CKD equivalent to CKD 2 and 3, low bone turnover. If you have severe CKD, you have high bone turnover. So,
well, this actually strongly relates to the question which is posted by Tillman-Drucke. You already mentioned him. And Tillman is asking if you think that there is a parallel change between uremic microbiota and the phenotypic change in the progression on bone in the progression of CKD.
Tillman asks always a good question. I agree that we don't have the data, but to my opinion, if it is, we need to distinguish how deep is butyrate deficiency in our patient. We know that butyrate, at least for bone formation, if you have physiological elevation of butyrate, you have reinforced the effect of PTH. If you have high level of butyrate, you may have independent effect of the immune cells and the osteoblast and bone formation. What happened from bone resorption, I don't know, but it's different between the concentration of butyrate. This could be play like that. If you have maybe low, maybe limit deficiency on butyrate, you may have maybe an effect. And if you increase the level of increase the deficiency of butyrate, you may have more effect. I don't know the answer in CKD, but this could be related to concentration of butyrate. I know for the bone formation, I don't know for bone resorption.
And what do you think would be the most suitable way to answer this question? Either go for a longitudinal study and look as patients progress and kidney functions declines, how changes in microbiota precede or correlate with changes in bone markers? Or do you think that it's best to look for a cross-sectional study in advanced CKD in which you have different bone phenotypes and then look at whether these different bone phenotypes also have difference in the microbial composition, so to say? What do you think would be the most informative?
I think both are needed to answer the question. I think not only microbiota, but we can start with sample one. You can have a level of butyrate in CKD stage 2 and 3 and CKD 4 and 5 to see what the difference of the level. For microbiota, we will have some data from CKD ramp, but our patient is, all of them is 3 and 4. And so we don't have early on CKD stage 2, but at least from preliminary data, there were no modification of the microbiota. But doesn't mean that in quantitative way, but doesn't mean that product of microbiota is not changing too. So to me, one simple question to answer for this longitudinal data is look about butyrate and then see what happened if butyrate was correlated with the bone alteration, if you have a bone biopsy, as you do in Leuven and other people do too.
Mm-hmm.
I would like to give Letitia the opportunity, and then I will go to the question by Pablo Urenia.
Yes, I would like for your opinion, what is the better strategy to modulate the microbiota? You say there are no change in the quantity, and you say that the butyrate is decreased, and when you increase the butyrate, it could have a benefic impact. Should we go to the specific strategy, like one bacteria, one postbiotic like butyrate, or should we have a global approach like symbiotic, or more than fecal microbiota transplantation to restore the microbiota? What is your opinion?
You mean in CKD patient or in general?
CKD patient.
In CKD patient, I think it's we can do that. This has been, at least in animal model, show that probiotic supplementation modify the level for butyrate, but you can have also typical strategies. That's what they have, what colitis, the Clostridium, they take one of bacteria and inject it to microbiota to have a predominant species, and then you have protection. So until we know which bacteria is bad and which bacteria is good for our patient, we cannot answer. But I think there are two possible that you can use a probiotic to change, but I think in the future we will come to have one or two bacteria which have maybe a role in this microbiota, and if we inject them with it have been done actually for this colitis, and it can modify the microbiota in our patients, see what happened in the product of microbiota, what happened in the bone and other tissue.
So the question by Pablo is, do you know, Ziad, if intestinal derived butyrate can also regulate the type 1 PTH receptor?
Pablo, is a nice question. I don't know. I assume that is not the case, but because they have a specific receptor by themselves, GRP 41 and 43, but I don't know the question. I cannot answer.
But the effect on the PTH receptors can also be mediated by immune cells.
Right, because the PTH receptor can be modulated by PTH already. I mean, this is or we have some other molecules like even uremic toxin too. But this is the reason. For example, you have phosphate, for example, can modulate PTH receptor in the bone, have resistance to action of PTH. So, but I don't know if the butyrate can modify the PTH receptor. I don't see any paper about that.
There's a question from Dieter Schmout, which is related to what we just discussed. And the question is, does intestinal and serum levels of butyrate, we know that these are decreased in higher stages of CKD. And the question is if there also is a correlation in individual subjects between intestinal and serum levels of butyrate.
In this paper, they don't have this analysis to look about the correlation between intestinal and serum level, but I assume that butyrate have two actions. One of them is the increase, protect against absorption by decreasing, tightening the paracellular pathway, but have a specific receptor to be absorbed. I don't know what happened of this receptor for butyrate in CKD. This could be also one way to look at, because if we know that globally speaking, CKD can modulate the receptors, and if we have this monocarboxylate transporter modify, maybe we have less butyrate absorbed or whatever. Globally speaking, in CKD, the majority of receptor is blocked or have down regulated or have down function, except few of them like morphine receptor mu1.
Yeah. Bjorn.
Yeah, I was just wondering, because there are now a multitude of studies trying to target the microbiome in CKD using different approaches. Do you think it's necessary to include PTH as a secondary endpoint in all of these studies? Or at this stage, would you say, well, we just don't know enough for now, so it's not necessary?
I think it's the best things to look is the bone, because it is I don't see any effect of butyrate about PTH level, but I know by experience in animal model that we look only for one time point, but usually when you have hypocalcemia and hyperphosphatemia, you have a peak of PTH, and then you normalize the level of phosphate, and then PTH become normal. So I don't know what happened about this variation of PTH in, let's say, in CKD stage 2 and 3 in comparison to continuous elevation of PTH. Intermittent PTH actually is good for the bone, as you see that I show you. This is mean that it can help to have a bone formation. So I think it's difficult to look to the PTH alone, because it's sometimes it depends the time when you have elevation down, especially in early stage, and later stage is no problem for stage 4 and 5. But I would look better in bone tissue, that is because you have now fixed data to see if you have resorption, formation, both, whatever.
Thank you. Before I go to you, Letitia, I want to give attention to the next question by Pablo Urania. And the question is related to what we just discussed, if it's just butyrate. And the question is intestinal serotonin, which, if I am right, is derived from tryptophan, is also a central and peripheral regulator of bone turnover. And do you think, do you know if intestinal serotonin is changed in CKD? Which what you would expect, I guess.
It does. I should say that the serotonin can be modulated in CKD, but I remember this is pharmacological data, that all serotonin cross the pulmonary circulation and then destroy. So the serotonin level is unless you have a huge amount or of serotonin, you cannot see it in actually the serotonin in neurological system is completely independent what we have in the circulation. So serotonin is different story, and I'm not sure the level of serotonin is could be elevated. There are some data showing that serotonin can be increased in production in intestine, and it could be one marker of modulating microbiota. Whether this become increased in the serum, I'm not certain about that, because the disease of carcinoid, for example, you don't have manifestation unless you have a huge amount of serotonin cross the pulmonary circulation, which serotonin is always stray, and there's no connection with what happened in the neurological one. This is what the reason people, when they look about serotonin and cognitive disorder, they look only in neurological system. They don't look about systemic one.
Okay, thank you. Letitia.
Yes, I would like just to finish, maybe it's one of the last questions, but I would like to finish more a philosophical question. Why do you think it is an evolutionary good point that the gut microbiota and the PTH is regulate together? And what is for you your point of view about this crosstalk, and maybe with the diet or maybe like that? What is your opinion?
To my opinion, I think it's actually this is also the Pacific group opinion, that we don't need the butyrate or microbiota to have an action in the bone. I show you that we have sclerostin. If you have physiological levels of butyrate, you just reinforce the action of PTH. And it depends what you eat. This is for the reason you have a difference between patients. Actually, interesting enough, if you look primary hyperparathyroidism, which is a huge amount of PTH circulating continuously. If you look at the bone in this patient, some of them have bone disease, some of them have not. And the reason they difference is probably related to this microbiota, because they have maybe different diet, different microbiota, different butyrate level, whatever. So it's very important to look this as modulator of PTH level. This is my opinion, but this is not coming from me too, but it's Pacific opinion too, and have some data in primary hyperparathyroidism.
Thank you.
We still have a more practical question from Peter Sawaya. So probiotics without modulation of the environment would be useless, since the milieu itself is responsible for dysbiosis, which I think is true. Mediterranean diets may impact dysbiosis. And the question is if you are aware of cross-sectional study which link geographic regions related to diet and the effect on bone and inflammatory conditions.
No, I'm sorry. A very good question, Peter. I think it is this is one of the subjects can be done by CKD-MBD group to look about the difference between Greece and Belgium and Sweden. I don't know about the bone and inflammation and the microbiota. I can tell you we have just published a paper related to two uremic toxin, TMAO and CMPF. And TMAO is the product of red meat, and CMPF is fish meat. And we know the Swedish people eat more fish than red meat. And then we find that CMPF, which is protector, is more frequent, highly elevated in Swedish people than other countries. So yes, you are correct. There are probably some difference related to diet, and could affect some of the uremic toxin and could affect maybe the bone, but we don't have the data. This is a good project for European CKD-MBD.
It seems relatively easy to do, I would say.
Okay.
We have 3 more minutes left, which means that is only time for one burning questions. First, one of the panelists, maybe. There are no open questions in the chat.
I have no burning questions left, Marc, and so
okay.
I allow you to stick to the schedule.
Good. I have one philosophical question as well, Ziad. Do you think there might be a crosstalk the other way around? So does bone disease impact on the microbiota?
Certainly, but we wrote a good paper a few years ago together that bone is endocrine system. They can secrete some product to modulate the calcification, they modulate other people. And maybe we can look about some of the product of the bone, we can affect the intestinal barrier. I don't know study about that, but I think it's possible. Yeah, I agree.
Yeah.
It's,
Okay. Okay, we're close to wrapping up. I would like, before you all leave, please stay tuned because you will get a link to earn your CME credits. Before we wrap up, I would like to thank Ziad Massy first for your wonderful presentation, and you did a great job in discussing all these difficult questions. Thank you, Bjorn, and thank you, Letitia, for asking questions. I'm sure we have even a lot more, and I would especially like to thank Ira and all the attendees for making this all possible. I hope you found this a useful meeting.